Welcome to the Homeless Planning Council's Centralized Intake Information Session. Thank you for taking the time to learn about this new program in Delaware. Regardless of where you are positioned in Delaware's homeless, social, or health services systems, centralized intake will affect the work that you do. Therefore, please take the time to watch the entire presentation. Feel free to make note of anything if it's unclear, or if you have any questions, comments, suggestions, or concerns. After you've completed watching the presentation, you may send any of your questions or comments to me, Rachel Beatty, at the Homeless Planning Council of Delaware by email at intern@hpcdelaware.org or by phone at 302-654-0126. You are also invited to attend an open community dialogue session on centralized intake, at which time you can ask questions and make comments. We are holding 2 dialogue sessions. The first will be in Dover on March 1st from 10 a.m. to 12 p.m. at the Kent County Administrative Complex. The second will be in Wilmington on March 6th from 9 a.m. to 11 a.m. at the Community Services Building. We hope that you will join us at one of these times, and please feel free to inform your colleagues of this opportunity as well. We will now begin with an overview of the centralized intake model. Centralized intake systems have been proven to improve connections between people and the housing and services that they need. In 2011, the U.S. Department of Housing and Urban Development included in their Emergency Solutions Grant and Continuum of Care regulations a requirement that all continuums of care develop a centralized intake system in their community. By a date yet to be determined by HUD, the centralized intake system must encompass the entire state of Delaware and serve all subpopulations of persons experiencing homelessness. Examples of subpopulations include individuals, families, veterans, victims of domestic violence, the chronically homeless, and others. Not only are centralized intake systems now a HUD requirement, but they have also been proven to improve outcomes for persons who experience homelessness. Centralized intake systems can encompass a wide range of strategies and can differ significantly between communities, depending not only on the particular needs, strengths, and challenges of a community, but also by the unique populations that they serve. However, among centralized intake systems, there are common elements. Firstly, each system has structures and protocols that streamline and improve the screening, assessment, and referral processes within the homeless services system of that community. Secondly, each system will employ a standardized assessment tool with which every person who enters the homeless services system will be initially assessed. A standardized assessment tool ensures that all persons who are experiencing or at risk of homelessness are captured in our data, as well as provide the necessary information to ensure that persons and families are referred to the services best suited to meet their particular needs. Lastly, each system has an electronic information system that allows agencies to more effectively share information across the homeless services sector. In Delaware, the Continuum of Care already utilizes the Delaware Community Management Information System, or DECMIS. This system will continue to be used as the centralized intake information system. However, improved tools for sharing information and real-time system monitoring, such as real-time bed availability, will be added to the current system. Delaware's CMIS system will be discussed more later in the presentation. Centralized intake has many purposes. Firstly, centralized intake is meant to improve the experience of the consumer and the consumer's accessibility to appropriate services, not create additional barriers. Centralized intake will help the consumer locate the housing and services that they need as quickly and efficiently as possible. For example, instead of calling many providers seeking shelter, prevention resources, or other services, each consumer will be assessed and referred to the most appropriate place the first time around. Secondly, centralized intake will minimize the time that providers and their staff must spend screening and assessing people who are not right for their particular programs, and the time that they spend managing waiting lists. This will free staff to engage in more intensive housing case management with the consumers in their programs. Lastly, it helps to ensure that people are connected to the right housing and services at a community-wide level, as well as providing quality system-wide data. These will allow us to engage in effective system analysis and improvement. The HEARth Act was adopted by the federal government in 2009. In Section 1002, the HEARTH Act sets a federal goal that no one should experience homelessness for more than 30 days in the United States of America. The HEARTH Act also identifies performance measures of high-performing continuums of care. A well-executed centralized intake system will help Delaware's homeless services system improve their performance in these measures. Firstly, continuums of care should increase their program exits to permanent housing. Centralized intake will help people move through the system faster, thereby increasing exits to permanent housing by reducing the amount of time that people spend moving from program to program before finding the right match. It will also reduce new and recurring entries into homelessness by consistently offering prevention and diversion resources up front, thereby reducing the number of people entering the homeless system unnecessarily. Centralized intake will also improve data collection and quality. It will provide accurate information so that we can identify any unmet needs in our system, and it will help to inform our future efforts for improvement in our homeless services system in Delaware. Other communities with centralized intake systems include Miami, Florida, Lincoln, Nebraska, Dayton, Ohio, Cincinnati, Ohio, and Alameda County, California, for example. The National Alliance to End Homelessness includes examples of these models and others on their website. Feel free to visit this website in order to explore more examples of centralized intake systems across the country. In May of 2012, the Homeless Planning Council coordinated a community meeting that was facilitated by a HUD technical assistance provider. At this meeting, community members brainstormed and identified these 8 guiding principles for centralized intake in Delaware. These principles have guided the work of the Homeless Planning Council and the Centralized Intake Implementation Committee, and will continue to do so as we, as Delaware's homeless services system, all move forward together with implementation of centralized intake. Firstly, no side doors means that every person and family will enter the homeless services system through a designated door, or entry point. This is how we will ensure that all persons receive a standardized assessment and the most appropriate referral possible is made. Secondly, we will consistently and transparently assess client barriers to services, shelter, and housing using Delaware CMIS. Once we are able to accurately identify client barriers, we can begin to develop strategies for reducing those barriers and creating more accessible services. Centralized intake is also meant to streamline the enrollment process for persons seeking services. We want to ensure that everything we do makes the enrollment process more efficient, not more cumbersome. Also, as previously mentioned, we recognize the value of real-time data collection and ongoing system monitoring as necessary for informing how we address the needs of our community at a system-wide level. We've already covered the objectives outlined in the HEARTH Act. These objectives also inform our work. Next, client choice is a very important component of centralized intake. Consumers will not be forced to choose particular programs as a part of centralized intake. Consumers will be presented with options for services for which they are eligible, and they will engage in conversation with centralized intake staff around the best possible fit for their particular needs. Housing First is a philosophy that is used around the country in efforts to end homelessness for our most vulnerable population. Rather than focusing on making people ready for housing by moving them through different shelter programs, Housing First programs move people directly from the street, emergency shelters, or transitional housing programs into permanent housing. Housing is not contingent on their compliance with services, but rather with their ability as a tenant to comply with a standard lease agreement. Importantly, Housing First models do not leave people on their own without supports. In fact, case managers continue to engage with people while they are living in their own homes, providing whatever supports they need to remain in their housing. We believe that the most vulnerable of us deserves and is able to maintain permanent housing in our community. This belief guides our action. Last but not least, centralized intake must be a program that is trauma-informed. In this context, trauma-informed care is an approach to engaging with persons experiencing homelessness that recognizes that the experience of homelessness is in itself a very traumatic experience. A trauma-informed care approach also recognizes the presence of trauma symptoms in people, and it acknowledges the role that trauma has played in their lives. For example, instead of asking, "What is wrong with you?" a trauma-informed care approach asks, "What happened to you?" As we implement centralized intake, we will wear a trauma-informed lens and work to ensure that the centralized intake process reduces, rather than heightens, the traumatic experience of being homeless in Delaware. Now we are going to look at the implementation plan for centralized intake in Delaware. Here in Delaware, the Homeless Planning Council is the management agency of the centralized intake system. There will be one centralized intake program director and 4 housing specialists who staff the program statewide. The centralized intake program director will be responsible for administrative oversight of the program and will ensure that centralized intake is consistently evaluated and improved upon as implementation moves forward. Housing specialists perform assessments with consumers, hold waiting lists, and make consumer referrals to appropriate programs and services. Due to the varying landscape and culture of Delaware's northern and southern counties, our plans for implementation vary slightly by county. We also recognize the need for multiple doors or entry points into the system. In Newcastle County, there will be one housing resource center that is located in Wilmington. That resource center will serve as a single physical point of entry for persons in housing crisis. The center will be staffed by 2 housing specialists. One of those housing specialists will be mobile at all times, traveling to meet people where they are across Newcastle County. There will be 2 housing specialists assigned to Kent and Sussex counties, both of whom will be primarily mobile. There will be no single physical point of entry in those counties. Those workers will have a home base or office to work from when needed, but they will both be primarily mobile workers. Centralized intake housing specialists will not act as case managers for consumers. Case management will continue to occur in the appropriate system, with provider staff, social service staff, health service staff, and others. However, the housing specialists will assist consumers in connecting them with the case management services they need when necessary. We recognize that transportation is a concern for many Delawareans and can be especially inhibiting for those without sufficient income or who are experiencing a crisis. Throughout the centralized intake planning process, we have found ways to manage this issue that we believe will make transportation less inhibitive. Mobile housing specialists will help us address this problem. Mobile housing specialists will travel throughout the state, throughout their designated counties, in order to meet persons who are in housing crisis where they are. Using mobile tablets, they will be able to perform assessments on location, whether in the streets or at an agency. They will also help to ensure that all persons in need of transportation assistance are able to access the services that they are referred to, either by directly providing transportation, working with other agencies to do so, or providing bus vouchers when needed. Each housing specialist will work from a trauma-informed perspective, ensuring not only that each consumer reaches their intended destination, but that they do so in a way that does not further aggravate their senses of safety and security. They will be responsible for ensuring a warm handoff of consumers to providers or other intended locations. Now we are going to shift gears a bit. We're going to move from looking at the overall structures of the centralized intake system and implementation plan to looking at how the consumer will move through that system on a more detailed level. This consumer flow chart indicates where we are in the overall centralized intake process. We will continue to come back to this chart throughout the presentation as we move through these steps. We will begin by reviewing the initial steps that will be taken when someone in Delaware is experiencing a housing crisis. Persons who are in housing crisis will be initially assessed using the Housing Crisis Triage Assessment. This is the first step in seeking housing assistance. The triage assessment is a brief questionnaire. Its purpose is to determine one's current housing status and to identify their immediate housing needs. Importantly, in cases of domestic violence, the consumer will be immediately connected with the state's domestic violence hotline or other services. Here is the housing status and need level summary form. This form will be used along with the triage assessment as a guide for determining a consumer's housing status and need level. As you can see, a consumer may fall into one of 4 housing status categories: literally homeless, imminently homeless, unstably housed and at risk of homelessness, or stably housed. At the bottom, their need level will be determined as well. This form should be used as a guide for making these determinations. This document is the Assistance Response Matrix. It serves as a basic guide for providers to use following the triage assessment. This matrix outlines the appropriate course of action once a housing status and needs level determination has been made for the consumer. If it is determined that a consumer is unstably housed and at risk of homelessness, then they will be referred to the most appropriate prevention resources, such as landlord-tenant mediation, rental assistance, housing search assistance, energy assistance, or other kinds of prevention assistance. This will help to ensure that persons are connected with prevention resources up front and do not enter the homeless services system unnecessarily. If, however, the consumer is determined to be imminently or literally homeless and in need of homeless services, the consumer will enter the homeless services system. While this diagram might look complicated, it's really rather simple. Our intention with this diagram is to illustrate all of the ways that consumers who are in housing crisis might seek assistance, and to be sure that each entity that comes in contact with a person experiencing housing crisis has clear instructions about how to proceed. Firstly, you'll notice in the top left-hand corner of the chart, a consumer may go directly to the New Castle County Housing Resource Center in Wilmington if they are experiencing a housing crisis. Upon arrival, the consumer will be seen by a housing specialist on location. The housing specialist will perform the triage assessment with the consumer and input the data directly into the Delaware CMIS system in real time. Secondly, a consumer may be with a service provider in the community at the time of a housing crisis, such as a hospital, a mental health care facility, a detox facility, a church outreach center, a state service center, a prison, or any other non-homeless services provider in Delaware. Their housing crisis might be due to lack of housing upon discharge from a facility, or maybe they have gone to a service provider seeking help with another crisis. At that time, the service provider may do one of 2 things. The service provider may have the consumer call Delaware 211, at which time Delaware 211 will perform the housing crisis triage assessment with the consumer over the phone. Or the service provider may perform the triage assessment his or herself. The triage assessment, housing status, and need level summary form and the Assistance Response Matrix forms will all be available on the Homeless Planning Council's website, www.hpcdelaware.org. The triage assessment will be available as both a web form and in printable format. If the provider chooses to use the web form, the completed form will be submitted and automatically sent electronically to Homeless Planning Council staff. The staff will then enter that data into the Delaware CMIS system. If the provider chooses to print the form and fill it out by hand, the form must be faxed to the Homeless Planning Council of Delaware so that the data can be immediately entered into Delaware CMIS. If the consumer is determined to be imminently or literally homeless, the provider will then call the Homeless Planning Council of Delaware. Using a phone extension system, the Homeless Planning Council staff will transfer the provider directly to the nearest housing specialist. This transfer will be as simple as pushing a button. In New Castle County, the call will be transferred directly to the Housing Resource Center in Wilmington. In Kent and Sussex counties, the call will be connected directly to a mobile housing specialist's cell phone. Thirdly, a consumer in housing crisis may be in crisis and call Delaware 211 directly. Once it is identified that they are having a housing crisis, Delaware 211 will perform the triage assessment with the consumer. Again, if the consumer is determined to be literally or imminently homeless, Delaware 211 will connect the consumer directly to the Homeless Planning Council of Delaware. The Homeless Planning Council will then transfer the consumer directly to a housing specialist. A fourth way that a consumer may seek assistance when in housing crisis might be by going directly to a shelter or homeless services provider in the area. Homeless services providers will not perform the triage assessment. When persons seek assistance from a homeless services provider, we can assume that they are literally or imminently homeless. The provider will refer the consumer to call Delaware 211 to be assessed. Or they can call the Homeless Planning Council of Delaware, and the Homeless Planning Council of Delaware that will then connect the consumer directly to a housing specialist. If at any time a consumer is connected directly to a housing specialist without having completed a triage assessment, the housing specialist may perform that triage assessment as well. However, we anticipate that housing specialists will be kept busy performing full intakes with consumers as well as making program referrals. Therefore, we intend for the vast majority of persons who are literally or imminently homeless to have received a triage assessment prior to seeing a housing specialist. We have just covered the triage assessment process. If it is determined that the consumer is in need of homeless services, they will move on to receive a standardized intake and enter the homeless services system. At this point, the housing specialist will certify the consumer's homeless status. Now let's talk in more detail about the standardized intake process and procedures. All intakes will be conducted in person by a housing specialist, and all information will be entered into Delaware CMIS in real time. There are 5 main components of standardized intake. Firstly, all HUD data elements will be collected. Centralized intake will ensure that we gather complete and quality data for each person entering the homeless services system. Secondly, each consumer will be assessed using the Housing Risk Barriers Assessment Tool and the Vulnerability Index. These tools will help the housing specialist determine the types of programs that best meet the consumer's individual needs. We will look more closely at those tools next in the following slides. Next, the housing specialist will use the eligibility tool in Delaware CMIS. This online tool will tell the housing specialist what programs that consumer is eligible for and which programs the consumer is not eligible for. Most programs have criteria with regards to registered sex offenders. Therefore, each consumer will also be checked in the National Sex Offender Registry. Any other criminal-related concerns must be dealt with at the program level. Once one or more program matches are identified, the housing specialist will check for bed availability in those programs using the Shelter Point module in Delaware CMIS. If there is an open bed, the housing specialist will begin the referral and bed reservation process. At intake, each consumer will also sign a confidentiality agreement. The consumer will choose whether or not to allow their intake information to be shared with other agencies in Delaware CMIS. If the consumer chooses not to share their information, the provider might be required to perform the standard intake with the consumer a second time upon program entry. Here is the Housing Risk Barriers Assessment Guide for best determining a consumer's housing risk level. The National Alliance to End Homelessness, with support from researcher Dennis Colhane, developed this tool. The assessment takes into account the consumer's rental history, criminal history, history of substance abuse, mental health, employment, abuse history, disability status, income, and a few others. All of these questions will be a part of the standardized intake. In the title cell of each column, each housing risk level is associated with a particular type of program. Those program types are listed in the brackets. You will notice in levels 2, 3, and 4 there are multiple options for program type. The fact is that each person has individual needs, and not all attributes will be present for everyone at each one of these levels. Therefore, this is not and cannot be an exact science. It is an assessment meant to be used by the housing specialists as a guide for determining good program matches and referrals for each consumer. This is an overview of the Vulnerability Index. Boston's Healthcare for the Homeless developed this research-based index for identifying the most vulnerable homeless. Housing specialists will use the information gathered during standardized intake to determine one's vulnerability score. In order to be potentially scored as vulnerable, a consumer must have been on the streets for at least 6 months. Then a consumer score can be as high as 8 depending on how many +1 scores are received. Consumers are scored with a +1 for each of the indicators that are listed. Consumers' vulnerability scores will be used to prioritize them on waiting lists and for services, with the most vulnerable at the top of the list. Here we are, back on the consumer flowchart, and you can see that we've just covered the standardized intake elements. Now I would like to briefly touch on diversion. Diversion is a strategy that diverts people who are literally homeless out of the homeless services system by identifying immediate alternative housing arrangements and, if necessary, connecting them with services and financial assistance to help them return to permanent housing immediately. Following a full standardized assessment, a housing specialist may determine that a consumer is a good match for diversion from the homeless services system altogether. These consumers have very few housing risk barriers, do not score as vulnerable on the index, and are only in need of some assistance in order to briefly end their episode of homelessness. It is helpful to think of diversion as closing the front door of the homeless services system. The link provided is from the National Alliance to End Homelessness website. At that website, you can find an informative brief on diversion and more description of the kinds of diversion programs that are available. Although Delaware currently does not have financial resources for diversion, we recognize the importance of these programs to preventing and ending homelessness in our state. As we implement centralized intake without these financial resources for diversion, housing specialists will utilize other resources as available in order to divert consumers from the homeless services system when possible. Now let's move on to the next section, referrals. In this section, I will explain the referral process that follows the completion of the standardized intake. Notice where we are in the process. Most consumers who receive a standardized intake will be referred to a homeless services program. Referrals and bed reservations will be made by housing specialists only. There will be no side doors into the system. However, due to funding requirements of particular agencies, there may be some programs for which this does not apply. Some funders, for example, require that referrals come from particular sources. Furthermore, due to the way in which rapid rehousing programs are operated, there are also some exceptions to entry for rapid rehousing programs, and we will talk in more detail about that shortly. This chart outlines who will have responsibility for what in the centralized intake system according to the kind of homeless services program. Each column represents a particular program type, and each row indicates a particular action. The contents of each box indicates who will be responsible for that action as it relates to each program type. For example, if you look at the first row, centralized intake housing specialists, abbreviated HS, are responsible for performing all standardized intakes. However, you will notice that for rapid rehousing programs, it may be possible for a rapid rehousing outreach worker to perform the initial intake with the consumer as well. This is the case because of the way that current rapid rehousing funds in the state are administered. There is rapid rehousing money specifically for veterans, and the program is administered through an outreach model. Therefore, we want to ensure that rapid rehousing staff persons are able to quickly assess and move the persons that they identify into housing. The rapid rehousing worker, however, may also refer the consumer to a housing specialist to perform the intake. For emergency shelter and transitional housing programs, the housing specialist will perform the intake, make referrals and bed reservations, as well as manage the waiting lists. Permanent supportive housing programs are a bit different. Permanent supportive housing staff will continue to manage the waiting lists for their programs. Their programs have traditionally long waits, and their beds or units are often available at multiple locations. Their process for entry is also a bit more complicated, as it involves signing a lease and other administrative tasks. For this reason, permanent supportive housing staff will continue to manage their own waiting lists. However, housing specialists will still perform all of the initial standardized intake and make the referrals. Permanent supportive housing staff will take the referrals that are made and place those consumers on their waiting lists. Permanent supportive housing staff will use each consumer's housing risk level and vulnerability index score to prioritize consumers on their waiting lists, with those with the highest housing risk level and vulnerability scores at the top. Rapid rehousing providers may receive referrals from a variety of locations: housing specialists, rapid rehousing outreach workers, or emergency shelter and transitional housing staff. Again, it is currently structured this way due to current rapid rehousing funds here in Delaware. Individuals are not eligible for rapid rehousing unless they are literally homeless, which means living on the street, in an emergency shelter, or transitional housing program. Emergency shelter and transitional housing staff may also make referrals for individuals to rapid rehousing programs under this new model if they identify someone in their program who they think would be a good match for rapid rehousing. They may also refer that person back to a housing specialist with a recommendation that a rapid rehousing referral be made. No matter the referral source, rapid rehousing staff will be responsible for managing their own waiting lists. As funding sources and/or program models change, these processes might change as well. Centralized intake staff will be responsible for informing all agencies of any changes prior to their implementation. We've mentioned referrals and bed reservations, but we haven't yet talked about them. Referrals and bed reservations are two different, separate actions. In order to make a referral for a consumer, a housing specialist will communicate directly with program staff either by phone or by another form of communication if preferred by that program. The housing specialist will also indicate that referral electronically in Delaware CMIS. More than one program referral may be made at a time. For example, a consumer may be a best match for permanent supportive housing. However, permanent supportive housing has traditionally long waiting time. Therefore, a housing specialist may refer a consumer to a permanent supportive housing program and also to an emergency shelter for immediate relief while they wait for permanent supportive housing. Bed reservations, on the other hand, will only be made one at a time. You can think of it as almost like a hotel management system. The housing specialist will enter the Shelter Point module in Delaware CMIS and look at the particular programs for which the consumer is eligible and for which are a best fit for their needs. The housing specialist will be able to see if any beds are open. At that time, the consumer and the housing specialist will decide whether or not to make a bed reservation in a particular program. Once the bed reservation is made, the provider will be sent notification through Delaware CMIS and by phone by the housing specialist that the bed has been reserved. To use the example just mentioned above, a housing specialist may send a referral to an emergency shelter and permanent supportive housing program for one particular consumer. But the housing specialist would then also make a bed reservation in that same emergency shelter that he or she had just sent the referral to. Referrals will not be sent to emergency shelter or transitional housing programs without a bed reservation as well. And vice versa, bed reservations will not be made in emergency shelter or transitional housing programs without being accompanied by a referral. Providers will keep their bed availability updated in Delaware CMIS in real time. Each time a person is exited from a program or a bed becomes available, the provider will indicate in the Shelter Point module in Delaware CMIS that the bed is open. However, we recognize that it can take some time, especially in transitional housing programs, to turn over a bed. Bed and rooms need cleaning and other maintenance. Therefore, the provider may indicate that a bed is open, but they may place what is called a hold on that bed. Once the bed is ready for a new consumer, the provider will remove the hold on that bed in Shelter Point, and it will become available for a housing specialist to make a hold and a bed reservation. Importantly, in Shelter Point, providers can indicate the composition of particular beds, units, or rooms. For example, if you are a transitional housing program and room 1 is on the first floor and has 3 beds, it can be indicated in Shelter Point that that room is designated for one family. Therefore, a housing specialist might see that there is an open bed in room 1 on the first floor, but that the other 2 beds are full. They will then know that that third bed is not available to anyone who is not in that family. Since multiple housing specialists will be working simultaneously to place consumers into programs, housing specialists will make holds on beds that are indicated as open for the consumer for whom they are also making a reservation. This ensures that for each reservation that they are making, a bed is being held for that person. Holds and reservations are different actions in Delaware CMIS. As you can see, reservations are made below the list of beds and bed holds. Once a housing specialist holds a bed for a consumer, they will scroll down to the bottom of the page and add a reservation, indicating the basic demographic information of that consumer, such as their age and gender. There will also be a link to the consumer's profile in Delaware CMIS. This information is available for viewing immediately by the program. The housing specialist will then contact the program and inform them that a reservation has been made. In order for the system to work effectively and efficiently, it is essential that all providers update Delaware CMIS regularly. Some things will need to be updated immediately on the same day. Those things include entries and exits from programs, including reasons for exits, and consumers' destinations when they are exited. And of course, bed availability in shelter point. Within 3 days, changes that occur for a consumer, such as their income sources and levels, employment status, etc., should also be updated in Delaware CMIS. Now that we have covered referrals and program admittance, let's move on to talk about referral refusal and case conferences. Each homeless services program will accept 75% of all referrals made to their programs per month. If they choose to refuse a referral, they will document their reason in Delaware CMIS. At that time, the provider will engage in a case conference with the referring housing specialist and the consumer. Each program will accept all of the consumer referrals made to their programs for at least one night. This helps to ensure that our system's beds are utilized and that as few persons as possible must spend nights on the street. If an agency chooses to do so, they may refuse that referral the next day and must engage in a case conference. Case conferencing is an important part of the centralized intake system. A case conference is a three-way or more conversation between a consumer, a housing specialist, and program staff aimed at finding the most appropriate housing and/or services match for each consumer. A case conference will be required when a program refuses a referral that's been made by a housing specialist and when a consumer is exited from a program into homelessness. To clarify, program staff may refuse a referral, but they must also engage in a conversation about what kinds of other services or programs may benefit the consumer. Also, we want as much as possible for programs to avoid exiting consumers into homelessness. However, when it does happen, the staff in that program will engage in a case conference as well. Case conferencing ensures that the consumer is included in the decision-making process around his or her service plans. It also ensures that housing specialists are informed and that everyone in the system is responsible for the well-being of each of our consumers. This will help to prevent some of the hardest to serve consumers from falling through the cracks in our system, and it will also make us more aware of the unmet needs of our consumers and how we, as a system of providers, can better meet their needs. Now we are going to move on to talk about program exits. It is our goal that in Delaware, all consumers are exited from the homeless services system as quickly as possible into permanent housing that is sustainable. However, we recognize that for a variety of reasons, this may not be the case for all consumers at this time. Under the centralized intake model, providers will maintain autonomy over deciding when and why to exit consumers from their programs. All program exits will be documented in Delaware CMIS. But we do encourage programs to avoid exiting consumers from their programs back into homelessness. But when it is necessary, as already mentioned, a case conference will be required between the program staff, the consumer, and the housing specialist. Providers will not exit consumers directly to the street unless in an emergency circumstance. In other words, if a provider must exit a consumer from their program into the custody of an emergency services provider, we ask that the provider simply document the circumstance of that exit in Delaware CMIS. You will notice that we have now made it through the entire consumer flow process. Like all new programs, centralized intake will not be 100% perfect at the outset. For example, we can only currently estimate how many people will need standardized intakes in Delaware each day. We will have to wait for centralized intake to begin before we can truly understand the daily needs of our consumers. The process will be continuously evolving, and the Centralized Intake Program Director will be responsible for ensuring that the system is continuously monitored and evaluated both informally and formally by centralized intake staff, providers, and consumers throughout the network. Formal opportunities for feedback and evaluation will be provided to the Homeless Services Provider Network, consumers, and other stakeholders in our community through the use of online evaluation tools and meetings. Particularly at the beginning, crisis situations will be brought to the attention of the Centralized Intake Program Director for immediate troubleshooting. The process of implementing a cohesive and effective centralized intake system in our community is not a simple task. It is very complex, and we recognize that this information may seem overwhelming to some. It is a totally new component of our homeless services system, and it's a new way of doing things, and new processes can sometimes feel awkward or cumbersome. However, we also believe that once we work together to get centralized intake up and running in Delaware, it will be smoother, simpler, and more efficient than our current system, not only for us as providers, but also for the populations that we serve. This concludes our centralized intake information session. I hope you found this information useful and find it useful moving forward. Please do not hesitate to contact me, Rachel Beatty, at the Homeless Planning Council with any questions. We do hope that you will attend one of our community dialogue sessions during the month of March and help spread the word and invite some of your colleagues, coworkers, and friends as well. Thank you, and we look forward to working with you to make centralized intake a reality in our community.